presenting my research on the evaluation of the effectiveness of the air cavity correction parameter in the Eclipse Acuros XB algorithm for radiotherapy treatment planning of prostate patients. And I'd like to thank my supervisors, Masheed and Pejman. So a bit of background on prostate cancer. Prostate cancer is the most commonly diagnosed cancer and second most common cause of cancer death in men in Australia, with 1 in 6 men being diagnosed before the age of 85. Treatment of localized prostate cancer typically involves surgery, radiotherapy, or both. Radiotherapy can either be treated as external beam or brachytherapy or both. So in this project, we're looking at external beam radiotherapy of prostate cancer and a brief overview of the treatment planning process. So the initial stage in treatment planning, the patient will be imaged, typically as a CT, but an MRI or PET scan may be used as well. Then the target volume and organs at risk are outlined. Organs that are typically outlined include the bladder, the rectum, and the femurs. Then the treatment plan is created. This is done in 2 stages. The first is the optimization stage, where the dose distribution is calculated, and then the dose to the patient is calculated. Then there are safety checks and plan verification before the treatment can then be delivered. In this project, we're focusing on the treatment plan creation stage of this process. And the goal of the whole process in radiotherapy is to deliver the prescribed dose to the treatment volume while minimizing dose to surrounding organs. A bit of background on dose calculation algorithms. Most modern dose calculation algorithms use a model-based approach where the beam is separated into primary, secondary, and scattered components. Dose calculation algorithms typically use pencil beam, where the beam is divided into infinitesimally small beams, convolution superposition, or Monte Carlo techniques, where Monte Carlo can either be stochastic or solved numerically. The Eclipse Acuros XB algorithm is a dose calculation algorithm, a part of the Variant Eclipse treatment planning system, which is designed to provide accurate and rapid dose calculations for external beam radiotherapy treatments for beam energies between 4 to 25 megavolts. It calculates dose to the patient by numerically solving the linear Boltzmann transport equation, which describes the macroscopic behavior of radiation particles as they travel through a medium. The AXB algorithm solves the linear Boltzmann transport equation according to the following steps, starting with the creation of a physical map of the patient, which is divided into discrete voxels. Then the components of the photon beam source model are transported into the patient. These components include the primary and secondary photon source and electron contamination. The scattered photon fluence in the patient is then calculated, and from that, the electron fluence in the patient is calculated. The dose to the medium is calculated by integrating the stopping power of the medium over the calculated electron fluence for every output voxel. In the case of prostate cancer, due to the close proximity of the rectum to the prostate, air cavities may sometimes be present in the rectum during the time of a CT scan for treatment planning, which results in air cavities either being not near the planning treatment volume or overlapping with it. The air cavity may change in size or may not necessarily be present when the treatment is delivered, especially considering the treatment is delivered in multiple fractions. The attenuation of primary photons in air is less than in tissue due to its lower density, which results in less scattering of secondary particles and subsequently less dose deposited, which then leads to uncertainty in the dose distribution being delivered to the patient. There are multiple solutions to dealing with the presence of an air cavity in the rectum. One is to assign a density that's halfway between air and tissue to the air cavity which assumes that the air cavity may or may not be there during treatment. Another is the Eclipse XB algorithm has its own air cavity correction parameter, which reduces dose to the air cavity. The aim of this project is to evaluate the effectiveness of the air cavity correction parameter in the Eclipse XB algorithm for prostate cancer patients receiving radiotherapy in comparison to other techniques in order to minimize the impact of an air cavity in the rectum. So a brief outline of the research map began with a dose volume histogram comparison of different treatment plans made for a selected patient. Then a 3D printed anthropomorphic phantom was constructed. Treatment planning and delivery was then done for that phantom, and then the results were analysed. So starting with the DVH comparison, the CT dataset of a prostate cancer patient previously at St Charles Gardner Hospital was selected for a retrospective study in order to compare the dose volume histograms of 4 different treatment planning techniques for accounting for an air cavity in the rectum. The following 4 treatment techniques were employed, and the dose was calculated using both version 15.6 and 16.1 of the XB algorithm. The first technique was to assign a density between air and tissue for the air cavity, which assumes that the air cavity may or may not be present during the course of the treatment. The second was to assign the air cavity the density of the surrounding soft tissue. Then the GP override was used, which disables the air cavity correction parameter. And lastly, the air cavity correction parameter was applied. It's important to note that these techniques are implemented during the optimization stage of the treatment planning, so each represent a different treatment plan which had the same dose objectives. So the following are dose volume histogram comparisons for the 15.6 algorithm. To the left, you can see that the dose to the PTV agreed very closely for all treatment plan techniques. There's appears to be more sparing to dose to the rectum on the graph to the right for the DVH comparison for the half fill and surrounding density fill plans, whereas there is only a slight difference between the air cavity corrected and not corrected plans. The following is the DVH comparison for the 16.1 algorithm. Again, all 4 plans seem to agree very closely in dose to the PTV, and there is a much more similar agreement in dose to the rectum as well. Due to this, only version 15.6 of the algorithm was used in the next stage of the project. The next stage is the construction of the 3D printed anthropomorphic phantom, which began by segmenting selected organs using 3D slicer from the patient DICOM files. Organs selected were the femurs, bladder, prostate, and rectum. These organs were then exported as STL files into Fusion 360, and all organs were hollowed to a thickness of 3 millimeters, with hole inserts designed so each organ could be filled with tissue equivalent material. The prostate was designed to divide into 2 halves, which could then clip together in order to provide a film insert, which would be able to measure the 2D dose distribution away from the rectum. The rectum was designed to have 3 different air cavity sizes, which was achieved by scaling down the width and length of the original air cavity size so that 3 rectums of volume 63 centimeters cubed, 46 centimeters cubed, and 42 centimeters cubed were designed. These 3 rectum sizes were then imported into Fusion 360, and an ion chamber insert was modeled, as well as all 3 rectums were combined with an identical cylinder, so each rectum could be placed in and out of the same rectum stand to be glued into the pelvis body. Then all organs were glued into the femurs, bladder, and rectum stand were glued into position, where the bladder was placed on its own stand in order to raise it to the correct anatomical height. And to the right, you can see all 3 rectum sizes along with their ion chamber inserts. In order to determine the correct HU values and select tissue equivalent materials, the HU values were obtained from the patient DICOM files using 3D Slicer. For the body, the HU value was 1 and gelatin was selected as a tissue equivalent material. The femur had an HU value of 295, so Uracil 10 orange was mixed with plaster of Paris to reach this high density. The rectum was both left as an air cavity for half of the CT scans and was filled with gelatin for the rest. The same gelatin density that was used for the body was used to fill the rectum. The prostate was filled with a higher density of gelatin, and to match its HU value of 0, the bladder was filled with water. All gelatin used in this project was used as a mixture of water and vinegar in order to preserve the gelatin for a longer period of time. To the left, you can see the fully constructed phantom filled with gelatin, and to the right, you can see the phantom was sealed with a polystyrene lid, which was cut to the shape of the top of the phantom. Which brings us to the third stage of the research map, treatment planning and delivery. First, 6 CT scans were taken of the pelvis phantom, 3 with air cavities for each rectum size, and 3 with the rectum filled with gelatin for each rectum size. And in this slice, you can see both femurs, the rectum, prostate, and bladder. These 3 slices are of the different filled rectum CT scans. And you can see that in both the larger and smaller air cavity rectums, there are large air cavities of 4.6 centimeters cubed and 5.2 centimeters cubed, respectively. This is likely due to the positioning of the ion chamber insert, as this was also used to fill each rectum with gelatin. Because it is not positioned directly at the top of the rectum, it's not possible to tell if the tip of the rectum has been filled correctly, and then once the phantom was rotated onto its back for the CT scans, the air cavities moved to the anterior side of the rectum. Due to this, only the medium-sized rectum was used in this experiment. You may also see there are small air cavities above each of the organs. This is where each of the organs are removed and replaced, which just show that upsetting the gelatin results in small air bubbles forming. Due to the gelatin leaking from the phantom during treatment delivery, which you can see in the image to the left, film was also not used in this experiment due to avoid damage to the Linac couch. So the planning target volume, rectum, bladder, and femurs were segmented, and 3 treatment plans were created. The first was the rectum unfilled with the GPU off and the air cavity correction parameter on. The second was the rectum unfilled with the GPU on, and the as such, the air cavity correction parameter was disabled, and last with the rectum filled. Version 15.6 of the Eclipse AXB algorithm was used to calculate the dose distribution for each plan, and each plan was delivered to the phantom, and the dose to the rectum was measured with a CCO4 ion chamber. Which brings us to the last stage of the research map, the analysis of results. You can see the dose volume histogram analysis for all 3 treatment plans delivered to the phantom. Again, there appears to be high agreement between all 3 plans for dose to the PTV, and only a slight disagreement between plans for dose to the rectum. Although film was not used, the dose profile for each plan is shown below, and there appears to be little disagreement between all 3 plans for dose to the prostate, which implies that should film have been used, we would have expected similar results between all three plans. Again, this is a comparison between the air cavity corrected and not corrected plans, where the maximum dose difference between each of the plans is still under 2%. Below is the profile, left-right profile, which is near the air cavity and tissue interface, which shows, especially between the air cavity corrected and not corrected plans, there were a strong agreement between all three. Below is a table of the predicted dose by the treatment planning system, the dose measured in the phantom, and the relative difference for all three treatment plans. It was found that there was a mean relative difference of -1.2% for the non-air cavity corrected plan, -1.6% for the air cavity corrected plan, and -1.8% for the field rectum, where the uncertainties of each was determined by the range. Although film was not used in this project, the dose profiles show that dose where the film was positioned is not affected by the change in treatment plans. The measured dose where the air cavity is not corrected appears to agree more closely with the dose calculated by the treatment planning system, which was -1.2 in comparison with -1.6 and -1.8. However, both uncertainties in phantom setup and uncertainties in outlining the CCO4 chamber, due to its small volume, are expected to be larger than the difference between these values. Therefore, in this study, no significant difference was observed between the air cavity corrected and uncorrected plans. And I would like to thank my supervisors, Masheed and Pejman, for supporting me through this project and for taking measurements. And thanks again to Masheed for creating all the treatment plans in this project. I would also like to thank Ryan, Gabor, Minir, Zaid and Luke for all the support they have provided during this project. And thank you to Riley and Andrew for all the 3D printing support they have provided. These are my references. Thank you for listening.
Good. Excellent. Any questions from Rachel? That's lots of.
I have a question.
So yes, they.
Great job, Rachel. I like the presentation. Just a quick thing, just refresh me. The plans which you used all the plans use the same MUs, monitor units for the.
Yes.
Okay. So the plans were copied on all the different. You just copied the plans and you haven't re-optimized and so on.
Each plan was re-optimized.
Okay.
For different techniques.
It was a great presentation, Rachel. It was really clear. In terms of the DVH variations you showed, and some of them were starting to get large, and you've got a table in your thesis showing that sometimes constraints might be violated differently when you do or do not have the correction on. Where are those differences? Are they like the sensitive tissue is the rectal wall?
Yeah.
That's the sensitive area. So where are the dose differences happening? Is it in the wall or is it in the film material?
I don't actually know.
Mm-hmm. Fair enough. And I guess, a follow-up question might be like, how large would the effect need to be, do you think, for it to have some sort of clinical impact, sort of a noticeable effect?
I think if there'd been, if one plan had stood out significantly from the others, maybe double the relative dose difference. I think that might be a highlight for concern, but there were a few uncertainties in both setup and outlining that for the measured values we got, it's not easy to say.
Yeah. So your conclusion, I guess, then is that regardless of the correction, the effect's probably not that important clinically in the end.
Yes.
Yeah, that's fine.
So Rachel, maybe the profile can show the differences in rectum wall and infill. Maybe you can, based on the distance, you can find out where is the rectum wall and the differences. Okay, great. Any other questions? No question? All happy? Yes,
very well done, Rachel.
If there is no other questions, thanks very much, Rachel, and thanks everyone. We have more than 32 audiences. Great. Excellent.